I'm from the Department of Ophthalmology, ENT, and Neurosurgery because I am easily bored. And I'm going to talk a little bit about the treatment of dry eye, but I'm not going to use very many big words because I don't have a PhD. So, like Dr. Evinger told you, you have 3 layers to your tear film. And so you have 3 kinds of dry eye. You have a mucin deficiency, you can have an aqueous deficiency, or you can have a lipid deficiency. My mom got me these Apple Jacks because she sort of compulsively buys everything that has eyeballs on them, and if she saw those balloons, I would have 100 of them. So this is exactly what Dr. Evinger just told you about. You have conjunctival goblet cells, you have your lacrimal gland, and you have your meibomian gland, and you have to lay down this layer in exactly this order for it to work, and that's what blinking does for you. So to have these are where your goblet cells live in your eye. If this is your right eye, they're closer to your nose than they are to your ear. And this picture is as though we flipped the eyelids inside out. So they're on the insides of your eyelids, they're on all the pink part of your eye, and they're all covering the white part of your eye. So all of that area has little tiny goblet cells in it. So a mucin deficiency is the least common one that we get. Something must have really diffusely damaged all of that. And those things are pretty rare, but they do cause blepharospasm. One of them is Stevens-Johnson syndrome, which is a hyperreactivity usually to a drug. Chemical damage, if somebody throws lye in someone's eye. Congenital issues, where one of them is ectodermal dysplasia, and toxins, actually from drops, can damage your goblet cells. So that's why we always tell you, if you're using artificial tears more than 4 times a day, you're supposed to use preservative-free ones. And that's why, because the preservatives, particularly in susceptible people, are harmful to your goblet cells. Okay. So how do you replace mucin? That's sort of esoteric, and when we do that, we do it with mucous membrane grafts, and that's pretty unusual that we ever have to do that, but sometimes we do in these people who have been in burn units because they had Stevens-Johnson syndrome or some other type of, very bad scarring disease. So the aqueous deficiency, that's the water deficiency, and that's the one that gets all the press. That's the one that everybody is trying to inundate you with samples for, and that's the one that is really where the glamour is for this. So we have a natural decrease in tear secretion as we age. And we also can get damage to our lacrimal glands. You can have an infection that causes that. One of the common ones is Epstein-Barr or mumps. People have their immunity to mumps wear off, and they get infection with mumps, and that can cause permanent damage to the gland. Another common one is autoimmune. About 1 in 10 people who have dry eye actually have Sjogren's syndrome, which is a more diffuse autoimmune disorder. You can have trauma to the gland. You can have surgery. Somebody tried to biopsy it and sort of whacked some of the ducts. After that, you get this really frustrating thing where you have reflex tearing. So you have too many tears, and you go to the eye doctor, and he says, well, no, your eyes are dry. And you're like, no, they're not dry. They're really wet. Why are you not listening to me? Well, it's because of this whole reflex loop, and you get more tears than you actually need. So this is the lacrimal pump that Dr. Evinger was talking about. You have your orbicularis, which is the muscle that runs horizontally in the eyelids, and when it squeezes, it's going to flatten the eyelids and bring them together. And that pumps all of your tears away over towards your nasolacrimal duct. And I realized that if I'm pointing to the screen, you guys can't see me. It's like gesturing when I'm on the phone. So this lacrimal sac here drains down into your nose. Now, the other surprising thing, this is a truly grotesque slide, but it shows you that up here, this is taken from the side. This is called a sagittal view, so you slice right down through the middle. And the eyeball is sitting right in here, and these are your eyelids. And up in the very top pocket of your eyelid, in the very inferior pocket of your eyelid, there are a bunch of lacrimal glands. And those are all responsible for the sort of minute-to-minute tear secretion that you have. And then every time the trigeminal nerve fires and tells you, hey, you need more tears because it's dry, you get that from the main lacrimal gland. There are also some glands called the glands of Wolfram that are embedded in the lid tissue that have this. Oops. All right, so how do we increase the supply? Well, you have vendors here to show you. The one thing I would caution you about is with artificial tears, you guys know to be careful with the moderate, mild, severe dry eye indications. If you don't have really bad dry eye and you go to use a severe formulation, you're going to hate it, and you're going to think it doesn't work because it's going to be too thick for you. The intermediate step there are gels, which we often give people to use at night because they're water-based, so they're not so greasy and they're easy to clear in the morning when you get up and you just sort of have to blink a bunch. Ointments are really effective, especially overnight, but then you have to, anybody who uses them, you know you have to clear out your tear film in the morning because they're all greasy. So what if you could decrease the demand too? And I'm sort of a mechanic, and this is what I think about. I could decrease the demand by fixing any eyelid abnormality that you have. If your windshield wipers aren't working, I can give you new wipers, and I can make them actually contact your cornea. I can plug up the drains for the tears, either temporarily with little silicone plugs that we can pop out if you don't like them, or permanently with cautery once you've sort of enjoyed the temporary ones and proven that you're not going to come back hating me because you're tearing. You could occlude the surface of the eye, and this is what we do with people who have seventh nerve palsies, is we put either a little piece of saran wrap that we stick with Vaseline around the eye and slap a square saran wrap on there, or we take a moisture chamber, which is just a patch, a plastic patch that decreases evaporation because the air can't get through it. You can do that constantly, and some of the seventh nerve patients, until their nerve recovers, we have to do that. Or you can just do it overnight. So, a lipid deficiency, and this is what they call evaporative dry eye. This is the second type of dry eye that Dr. Evinger referred to. It's super common. It's disease of the meibomian glands. And the meibomian glands are in the eyelids, and they open right on the very edge of the eyelid. You can have that for any number of reasons, but most commonly, it's just things get thicker as we get older. Also, there's a lot of rosacea in people, and rosacea is notorious for causing this. Ectodermal dysplasia is one of the other congenital things that can cause this. You can replace the lipid. You could put in ointment, which is very, very crude, and it doesn't clear easily, but it does work for overnight. So if you're not really expecting to see much, that's okay. Or you could try to make the lipid glands work better. And these are all of the things that your ophthalmologist tells you. One of the keys is warm compresses, twice a day. They thin the secretions. They get all of the little plugs of stuff that looks like toothpaste under the microscope out of the oil glands. You can decrease the inflammation that's causing all of this. One way that we do it sometimes is a short course of topical steroid, which would be something like Tobradex or Blephamide, and we don't use it for more than 2 weeks because there are other side effects of the steroid that are not good. We can also use topical azithromycin, although my patients have had trouble getting that covered. That's an antibiotic that both cuts down on sort of the natural flora, and it acts as an anti-inflammatory. And you can give somebody doxycycline, and doxycycline works really well, not in antibiotic doses, even though it is an antibiotic, but the two downsides to that are it can give you stomach trouble if you don't take it with food, and it can make you sunburn easily. It also interacts with a lot of medicines, but if you put someone on a course of doxycycline for a while, it actually changes the nature of the oils so that they work better. Rosacea sort of deserves its own slide because so many people have this, and you think it may not actually affect that, but it causes pretty bad dysfunction of the disease, or of the eyelids. If you treat the rosacea, it helps the ocular surface. And the ways that most dermatologists do this are with Flagyl, which is metronidazole, or doxycycline orally, or you can use intense pulse light, which also gives you the benefit of you look younger after it. So if you have to replace all three, sometimes you can use a scleral contact lens. And here you see a scleral contact lens next to a traditional soft contact lens, which is what everybody's probably used to. Scleral contact lenses are difficult to fit, but if you find somebody who can fit them for you, they can make your life so much better. This little pocket in here is filled with either gel or serum or saline, and you pop it in, and it covers the ocular surface for however many hours until you take it out and refill it again. Most of my patients refill them about twice a day. This is one of them in place. And you can see it's much bigger. It also doesn't cause the sort of constant abrasion of the cells that regenerate the surface of your cornea because it goes over them. A soft contact lens sits there and hurts those because it bounces over them every time you blink. This one doesn't. This vaults over that and doesn't cause that damage. So my sort of elementary approach to treating dry eye, and it speaks for itself. This is my practice. Thank you.